Hello, everyone. This is Dr. Mickey going over the chapter 23, which is the pharmacology or drugs for lipid disorders. So it's drugs for hyperlipidemia or hypercholesterolemia. So it's the anti-hyperlipidemic drugs or agents. So let's start with the pathophysiology or what is hyperlipidemia. Which is the high levels of lipids in blood, which is considered to be the major risk for cardiovascular disease, which there will be atherosclerosis, atheroma, plaques formation, which will increase the resistance within the vascular system and would result in increased vascular resistance. Patients usually tend to be, or most patients tend to be asymptomatic until the intense cardiovascular disease or the symptoms of the cardiovascular disease produces these symptoms or manifestations. There is a genetic and lifestyle contributors or like etiological factors that would result in the development of this disease. And the three different terms for lipid disorders, we tend to interchangeably kind of use these three terms all the time, like hyperlipidemia, hypercholesterolemia, and dyslipidemia. So the hyperlipidemia, which is high levels of lipids in the blood, hypercholesterolemia is only the elevation of the cholesterol in the blood, and we'll go over different types of lipids in a few minutes. Then the dyslipidemia, which is the abnormal levels of lipoproteins, excess or deficient. The three different types of lipids between the triglyceride, phospholipids, and the steroids. The triglycerides, the natural fat, the phospholipids, essentially, or they are the essential components or chemicals to, or substances to build the plasma membranes. The triglycerides, the three fatty acid attached to glycerol, that's the type of triglycerides. And the steroids are the chemical structure, the common chemical structure in steroid nucleus or ring structure. Now, the steroids are necessary for the production of the vitamin D. They are necessary for the production of bile acids. They are also required for the production of the cortisol, for the estrogen, hormones like estrogen, cortisol, progesterone, testosterone. So the steroids are different from the triglycerides or phospholipids. The triglycerides, they are the three fatty acids attached to the glycerol. They are the source of the energy. They account for 90% of the total lipids in the entire body. The phospholipids are essential for building our plasma membranes. The steroids are in which the body makes about 70% of the cholesterol needed. The body is able to make about 75% of cholesterol needed. Now, the remaining 25% comes from usually comes from the diet, mostly animal product, and the limit or the allowance is 300 milligrams daily. Now, the lipoproteins are the carriers of the lipid molecules. They consist of cholesterol, triglycerides, and phospholipids with protein carrier. The three different types of lipoproteins are HDL, high density lipoprotein, which is we tend to say the good or the happy protein, lipoprotein. The low density lipoprotein, and then the very low density lipoprotein. Then the apolipoproteins, the three functions of these lipoproteins, it will activate the enzymes that metabolize lipoproteins. The apolipoproteins, they have three main functions. One of them is to activate the enzymes that metabolize lipoproteins. The apolipoproteins also, they increase the structural stability of lipoproteins, and they are responsible also for the recognition sites for cell surface receptors. These are the apolipoproteins. These are the three main functions for them. Now, the three different types of lipoproteins, we said we have an HDL, LDL, and the VLDL. So the LDL, which is a low density lipoprotein, which is its function to transport cholesterol from the liver to tissue and organs. And the LDL, which contains about 10% light triglycerides, phospholipids, about 20%, proteins, 25%, and about 45% of cholesterol. So that's the main function of the LDL, is to transport cholesterol from the liver to the tissue and organs. So they are carries the highest amount of cholesterol. So cholesterol is a primary core lipid. Cholesterol accounts for 45% of the LDL. So it accounts for the cholesterol is the primary core lipid of the LDL, 45%. So that's called the bad cholesterol. So it contributes to the plaque deposits and the plaque formation and the atherosclerosis and the coronary artery disease. And that has the greatest contributor or factor or etiology to develop for patients to develop the cardiovascular disease, especially the coronary artery disease, CAD, coronary artery disease. So the very low density lipoprotein, VLDL, which is a primary carrier of the triglyceride in blood. It's a primary carrier for the triglyceride in the blood. And through bodily processes, it become VLDL. So the VLDL, through bodily processes, they become the LDL, in which that there is about, the cholesterol accounts for about 10 to 15%. And it's highly consists of triglycerides. That's why we said it's a primary carrier of triglyceride in the blood. Now, the HDL, which is a high-density lipoprotein, is a good cholesterol, in which that it's manufactured in the liver and small intestine, and it reverses the cholesterol transport. Remember that the LDL, it will transport the cholesterol from the liver to the tissues and organs. This HDL is going to reverse the cholesterol transport, assist in transporting the cholesterol away from the body tissues and back to the liver. So transport cholesterol for destruction removal from the body. That's why it's a good cholesterol. So the total cholesterol should be less than 200, desirable. The optimal for the LDL to be less than 100, and the desirable for HDL to be over 60. And the triglyceride should be within range as long as it's less than 150. To maintain triglyceride to be less than 150. So this is the figure explains the progression in terms of the development of the atherosclerosis and the atheromatic plaque, or the plaque formation, when it develops over time, in which that there is a damaged endothelium. So when the endothelium is damaged, then that would result, that's the phase. The first phase of the atherosclerosis and atheromatic atheromatous plaque or the plaque formation begins with the endothelial damage. And the next that will be a fatty streaks and lipid core formation. And then the third stage or phase will be a fibrous plaque. The plaque formation is very complex in terms of the, as we describe each phase and what happens and what occurs in each phase is very complex in terms of the pathophysiological changes. But we'll just go briefly over the stages and phases of the plaque formation or the atherosclerosis, development of atherosclerosis, damaged endothelial damage, and then fatty streaks. That's the bed or the foundation for the plaque formation and fibrous plaque. So we have a streak and lipid core formation. And then the third phase will be the fibrous plaque, and there's a raised plaque. So now it's kind of formed plaque to occlude the lumen of the coronary artery. It's very visible now. And that is when it's removed through the cardiac interventional cardiology or the procedures to remove the atheroma, you'll see it like whitish, yellowish pieces or yellowish tissue coming out of being sized or removed through that atherectomy procedures in the cardiac catheterization lab. So that's the third one, the third phase, which is the fibrous plaque, and which is the raised plaque, and it's yellowish in color. And then the last one, which is the complicated lesion. Now, at this point, it's very complicated. That's when there is the thrombus, which is the red color. There's a thrombus, blood clot has formed on the top of the collagen, which is in kind of light bluish color. But there is a complete blockage now, almost like it's more than 90% of the lumen of the coronary artery is kind of blocked with this complicated lesion, and it's showing the large thrombus attached to the plaque, fibrous plaque, and now becomes even more occluded, and that is atherosclerosis, which is, as we said, is the high lipid and high cholesterol leads to atherosclerosis, and that would result in, and that will lead to the coronary artery disease. These are some of the complementary and alternative therapies to lower the lipids. Some kind of agents over the counter complement, CAM therapy that lower the lipids and cholesterol. Lifestyle changes, and this diagram presents the four main groups of medications that may lower the lipids and cholesterol: statins, niacin, bile acid sequestrants, and the ezetimibe. The statins, and we'll go over all the four different groups and what each group, the mechanism of action and examples of each group in terms of drugs or medications. For like statins, they interfere with the HMO-CoA reductase, specific enzyme. So it will interfere with this enzyme and which is the critical enzyme in the biosynthesis of cholesterol. The HMO-CoA reductase, that's the main enzyme, is going to result in the synthesis and production of cholesterol. So statins, they inhibit this enzyme, so that will eventually decrease and lower the cholesterol level and the main lipoproteins, especially the LDL. The niacin, it decreases both the very low density lipoprotein and the low density lipoprotein levels. So we need both levels of the VLDL and LDL to lower them to treat hyperlipidemia and dyslipidemia. So niacin will lower both of them. The bile and acid sequestrants, they bind with the attach and bind to the bile acids. Thus, it will increase the excretion of the cholesterol in the stool. In the bowel movement, we get rid of the excess of the cholesterol with the bowel movement. Ezetimibe, which is like, this medication or this proven meds will block the absorption of the cholesterol from the small intestines. So these are the mechanism of action of lipid-lowering drugs, the four main groups. And the main group is the HMO-CoA reductase inhibitors, which is the statin family, the statins, which is like Lipitor, atorvastatin, Lipitor, the prototype drug, and then we have other similar drugs that are very similar to the atorvastatin, which is like lovastatin, Mevacor, rosuvastatin, which is Reptor, and simvastatin, which is Zocor. So this is statin family, called the statin, which is because the suffix for all these medications will end with will be statin. So the statin family, we'll go over the mechanism of action and then the side effects of each one. So the statins, they interfere with the synthesis of the cholesterol, and they are the first drugs of choice to reduce the blood lipid levels. So the atorvastatin, for example, it's a prototype drug for the statin family. It's will be indicated for hyperlipidemia with the goal of reducing the risk of myocardial infarction and stroke. So statin acts by inhibiting the HMG-CoA reductase enzyme, which is responsible for the biosynthesis of cholesterol. So as the liver makes less cholesterol, it responds by making more LDL receptors in liver cells, which will result in increased removal of the lower density lipoproteins, LDL, from the blood. So blood levels, both LDL and cholesterol, will be reduced, although at least 2 weeks of therapy is required before these effects are realized. So it takes about up to 2 weeks of therapy, of being on statin since they start taking the statin, to see any apparent or real effects and actual effects from the statins. It takes up to 2 weeks. To enhance therapeutic effect from the statins, patients receiving the statins should be placed on an approved exercise program and diet low in saturated fat and cholesterol. The drug should be given in the afternoon or evening time, no hours. The evening or night hours is a must in terms of the administration time for the statins, and that's because the highest level of synthesis or biosynthesis of the cholesterol takes place during the nighttime. So when we administer the drug in the evening or nighttime, that will hit the highest level of cholesterol production. That's why it should be given evening or nighttime and not in the morning. This applies for all different types of statins. Let's say category X, in terms of pregnancy category X, then the woman should not breastfeed during therapy. The adverse effects of these statins rarely cause a discontinuation of therapy. However, that the GI complaints such as intestinal cramping, diarrhea, constipation are often during therapy. Very small percentage of patients may experience hepatotoxicity, but it always has to be been addressed in terms of that, before we start the statins, we need require that we ask request for a baseline liver function test, and then we have to monitor the liver functions to be monitored during the first few months of therapy, and frequently after that, once a year, twice a year. But the most serious adverse effect from the statins is rhabdomyolysis and muscle cramping and muscle pain, myopathies. So it should be contraindicated for in patients with serious liver disease or liver impairment, or patients with unexplained persistent elevation of the ALT or AST or any of the liver function tests also should be avoided or contraindicated. The drug or the statins interact with many drugs, like they interact with the azole family, which is the antifungal drugs. It interacts with the HIV protease inhibitors, which is the group of medications to treat HIV/AIDS disease. And so it should be contraindicated due to an increased risk of or for the myopathy and rhabdomyolysis. That's why it should be contraindicated or should not be given with the azole, antifungals, HIV protease inhibitors, and so forth. So the drug or the statins may increase the levels of digoxin level. Serum digoxin level may increase when it's given, with the statins, in addition to the oral contraceptives. The erythromycin may increase the atorvastatin levels 40%. Also, the risk for rhabdomyolysis may increase when we concurrently administer the atorvastatin or the other statins with the antibiotics like cyclosporins, with macrolide antibiotics. The ethanol alcohol should be avoided during therapy because of its effect on the liver function. Because both ethanol, alcohol, and the statin will have a significant adverse effect on liver function, so both shouldn't be given together. So ethanol should be avoided during the therapy with statins. So what is the myopathy? So we know that statins tend to result or develop or lead to a side effect called rhabdomyolysis or myopathy. The statins across the board, all of the statins with different intensities, they can injure the muscle tissue, causing muscle aches and pain, known as myopathies or rhabdomyolysis. So rhabdomyolysis is the breakdown of muscle fibers, usually due to muscle trauma or ischemia. So during the rhabdomyolysis, the contents of the muscle cells will spill into the systemic circulation, causing potentially fatal acute renal failure. And that's the danger of rhabdomyolysis, not just the myopathies and the pain, muscle pain and muscle ache, but also that could result in the spilling of these muscle cells, especially myoglobins, into the systemic circulation that result in the renal failure. The mechanism by which the statin can cause this disorder is unknown. So because of this hepatotoxicity side effect, prior to the administration, we should obtain a baseline results of baseline liver function tests, bilirubin, ELT, AST, alkaline phosphatase, and the baseline, the stent can be used in patients with liver disease, but not those with the alcohol or viral hepatitis. Shouldn't be given to patients with alcohol or viral hepatitis, infection of the liver or inflammation of the liver. The baseline liver enzymes, when we do these liver enzyme tests, so the baseline liver enzyme test should be done before, as a baseline, before the patient takes the statins, and then they should be measured again to be monitored every like 6 to 12 months, unless the patient has poor liver function, in which case the tests are indicated every 3 months. Second group of medications is the bile acid sequestrants, in which that these medications will bind with the bile acids to increase the excretion of cholesterol in the stool, the bowel movement. So it's used in combination with the statins. So it will be given with concurrently with statins. We have the Wilcol, which is Colcivilam, Wilcol, and we have the Colestipol, which is Colested. The Wilcol is the most commonly used drug from this group, in addition to the cholestyramine or Questran. So the drug bind with the bile acids, increasing cholesterol excretion in the bowel movement in the stool, and it's a lower. It's given to administer to lower the serum lipid levels. Patients with hyperlipidemia, hypercholesterolemia, dyslipidemia, from the Questran. So it's a powder that is usually mixed with fluid before being taken once or twice daily. And it is not absorbed or metabolized once it enters the intestine. So that's it doesn't produce any systemic effect. It may take 30 days or longer to produce its maximum effect. So the Questran binds with bile acids, which will contain the cholesterol. We see bile acids, they contain cholesterol. So the Questran binds with the bile acids in an insoluble complex that will be excreted in the stool. So the cholesterol levels will decline due to that fecal loss. So we mix the drug thoroughly with 60 or 180 mLs of water. You can give it with any non-carbonated beverage. You can give it with liquid soup. You can give it with different types of liquid formats, fruit juice, or so. Have the patient drink it immediately to avoid potential irritation or absorption in the GI tract. So ask the patient about their preference to be given, with water or any other form of liquid form, and then make sure that, that patient drink it immediately to avoid potential irritation or absorption in the GI tract. Obstruction, sorry, to avoid potential irritation or obstruction in the GI tract. So adverse effects patients, although the cholestyramine rarely produces serious side effects, but patients may experience constipation. The contraindications, it's contraindicated in patients with total biliary obstruction, and in those with patients with prior sensitivity to the drug. They are sensitive to the drug, should not receive it, or if they have biliary obstruction. And we can tell, or what are the main symptoms or manifestations of biliary obstruction. Usually biliary obstruction results in the patients when they have a clay-colored or whitish stool and dark urine. In addition to the bilirubin high and this, apparent or evident in the sclera, you can easily, see the icterus, which is the yellowish discoloration of the sclera and the skin. But mostly, in terms of the signs or manifestations of biliary obstruction, two main manifestations of the obstruction of the biliary tract. Two, white or clay-colored stool and dark urine. Drug-drug interactions, cholestyramine, it can bind to other drugs and interfere with their absorption, like the digoxin, tetracyclines, thyroid hormones, like levothyroxine, statins, thiazide, diuretics, should not be taken at the same time. So cholestyramine may increase the effect of the anticoagulant medications by decreasing the level of vitamin K in the body. So that's the drug-drug interaction with the anticoagulants, is that cholestyramine or cholesterol, it may increase the effect of the anticoagulants by decreasing the level of the vitamin K in the body. So cholesterol or cholestyramine should be taken at least 1 hour prior to other medications, because when taken with other meds, cholesterol or cholestyramine can inhibit the absorption of other medications. So taking the cholestyramine with food may interfere with the absorption of the following essential nutrients, like the calcium, the folic acid, iron, magnesium, vitamin B12, vitamin D, vitamin E, vitamin K, zinc. So constipation is the principal complaint with cholestyramine. All those patients, when they take cholestyramine, they complain of constipation. It can be minimized by increasing dietary fluid and fibers. If there is a need to prescribe stool softeners or laxative, then that would be the case to prevent constipation or to offset the side effect of constipation. Next group of medications to lower the cholesterol and hyperlipidemia or dyslipidemia is the fibric acid drugs, and the prototype drug is Lopid, Pantoprazole, Gemfiprozil or Lopid. That's the prototype drug for the fibric acid drugs, known as Lopid. Most practitioners, they call the drug or called by Lopid. It's the most effective drug available for lowering triglyceride levels. it can raise also the good cholesterol, which is the high density lipoprotein cholesterol. So the HDL can be raised by, with this drug, the lopid. It's the most effective drug to lower the triglyceride levels. The lopid, it interacts with specific receptor subtype. It increases the risk for bleeding for patients on warfarin. So have to be careful when given the drug when in patients who take warfarin or Coumadin. And also there is increase the risk for the rhabdomyolysis in patients who are already taking statins. The niacin, which decreases the VLDL levels, the niacin decreases VLDL levels, and it may result, or it has too many side effects, like flushing of the skin, hot flashes, nausea, excess of gas in the GI, diarrhea, and the most serious effect is hepatotoxicity. And some, patients with niacin, they developed gout disease, high uric acid production, gout disease. So we have to on patients taking niacin, we have to monitor their liver function, monitor the uric acid levels, so because that tend to result in gout, and monitor the blood sugar levels if patients who are diabetic. Back to lopid or fiprozole. Lopid, we said, treats severe hypertriglyceridemia or hypertriglyceride levels. And the adverse effects we mentioned as GI distress, watchful bleeding with patients on anticoagulant, and used with warfarin may potentiate anticoagulant effect. And that's why we have to monitor the patient's PT-INR while on Coumadin, warfarin, sodium. The lopid, it is less effective than the statins in lowering the LDL, but is very effective in lowering the triglyceride levels. So because it has less effectiveness than statins lowering the LDL, so that's why it is not the drug of first choice for reducing the LDL levels. It's always the statin. The dosage for the lopid, usually it's taken orally 600 or 1200 milligrams daily. Side effects, it produces serious side effects, but it may increase the likelihood of gallstones and they occasionally affect the liver function. So the most common adverse effects are the GI related, like dyspepsia, diarrhea, nausea, abdominal cramping. And it's contraindicated in patients with liver impairment, severe chronic disease, pre-existing gallbladder disease like cholecystitis or gallbladder stone, cholelithiasis, polylithiasis, cholecystitis. Drug-drug interaction, the glopid may increase the effect of certain anti-diabetic drugs, statins, and insulin. Increase the effect of these medications. In addition to also its concurrent, the effect on the anticoagulant, which may potentiate anticoagulant effect. So they will increase the anticoagulation effect if given with, for example, with Coumadin or warfarin sodium. Concurrent use with statins should be avoided also because that will potentiate the rhabdomyolysis and myopathies, which will make it even worse if it's given with the statins. There's ezetimibe or Zetia, which inhibits the absorption of cholesterol in small intestine, which result in a small reduction in the LDL. Very minimal reduction of the LDL from Zetia compared to like statins, for example. The serious side effect, we have minor side effects like the myalgia, upper respiratory tract infections, diarrhea, arthralgia. So therapeutic uses for Zetia is to reduce total cholesterol or the LDL cholesterol, and it's approved for monotherapy as the only therapy, and can be combined also with statins. And this concludes the lecture.